Hello, so this video is about spinal radiographs and common pathologies that affect the spine that you may be able to see there. My name's Hanny Anwar, I'm a spinal surgeon at the Royal National Orthopaedic Hospital. So, plain radiographs, x-rays, they're good at looking at some things, not good at looking at others. So in the spine, we tend to use x-rays for looking at alignment, for looking at bony anatomy, and also for looking to a degree at the soft tissues. They don't show the nerves, they don't show the discs apart from as a space between the vertebra. And so they're not particularly good at looking for causes of radicular pain and will only show some causes of neck or back pain. But they can be useful for trauma to see if there's a fracture. Degenerative diseases, they will show you degenerative change, sort of arthritis and so on. Sometimes they can be useful in infection and you can pick up malignancy in them, but it's important to remember that really MR imaging is the gold standard for looking for if you're suspicious of sinister pathology or if you want to look at the neuroaxis. It's important to have a systematic approach when you interpret any x-rays, and A, B, C, D, E is the way we usually do it in medicine. So starting off, we can look at alignment. Now, if you look at the image on the right-hand side as you look at the screen, you can see that this is a cervical spine and proximal thoracic spine x-ray. It's a plain radiograph. It doesn't say, but it's probably a PA image. And you always start by, when you present these things, by saying what it is you're looking at. So you're looking at a plain radiograph of the cervical spine, AP, orientation, and it's adequately exposed. You can see this all the way from C2 and occiput down to the proximal thoracic spine, probably T5. So you look at the alignment then, and essentially you look to see if the spinous process and the pedicles are in line. It looks like there's a very slight curve when you go right to the bottom of the picture, but you'd need to get further imaging in order to confirm whether that's truly the case, because obviously this is just in one plane, so that could be a projection due to a curvature in a different plane. And obviously an AP x-ray should be straight, the spine should be straight on that. Then you can look at the bones themselves. So what you should really do is trace out each bone and see if there's any specific abnormality you can see. You might see a fracture, or you may see that one of the pedicles is not visualized properly, indicating there might be a metastasis or a tumor there. And you should do the same with the ribs and the clavicles, and as much as possible, although it's all superimposed with the mandible, maxilla, and skull. The third thing is to look at the joints. So the joints and the cartilage are seen essentially on plain radiographs as gaps between the bones. And so if you look at the space between each bone, between each vertebra, you've got a disc. And if you see that there's a particular asymmetry in the space where the disc is, or there's lots of sclerosis around the disc, that might suggest to you that there's some kind of abnormality. So you can get some idea about the disc. Is there joint space narrowing or facet degeneration? You should look at the soft tissues. You may see soft tissue shadows, which you don't really want to miss, because they may really be relevant, or they may suggest something else that needs further investigation. So look in the soft tissues. Is it what you expect? Remember that the aortic arch, or the knuckle of the aortic arch, always appears just to the left side of the spine, roughly around T5, T6. So a little bit of soft tissue density there is okay, but elsewhere it may not be. So it's something to look for. And then, of course, foreign bodies, extra findings. So if there's screws in the spine, screws and rods, whatever it may be, you also want to mention them. Now, of course, you may look at an x-ray, a plain radiograph, and say, well, there's an obvious abnormality. The spine is dislocated, or there's an obvious, very severe fracture here or there, or whatever it may be, or the whole spine is full of screws. It's fine to mention the most obvious finding first, but you shouldn't miss all of these, A, B, C, D, E, and comment on all of them. Right, so we start with the neck. So the neck, the cervical spine, goes from C1, just beneath the occiput, beneath the foramen magnum, and goes down to C7, the 7 cervical vertebrae. The top two, the atlas and the axis, are specialized vertebrae, which don't look like the others in the cervical spine. And that's where you have the odontoid peg and the and the atlas. But beneath this, you have the subaxial spine, C3 to C7, and these are typical cervical vertebrae, and they are different from vertebra in the rest of the spine. So the typical views we see an AP view, which we've talked about already. So this is front to back, antero-posterior, and you can look through the things that we've already mentioned. And you can also get a lateral view, and that's from the side, and you can see all the way up to the occiput, and here you get a better view of C1 and C2 than you do on the plane AP. You can see the C1, it just looks like there's a little bit of bone in front of the peg, and then there's the spinous process behind. And C2 you see is quite a large vertebral body with the odontoid process jutting up into the space that is provided to it by C1. And then the typical vertebra below that, C3 down. And an adequate film would mean that you can see the top of the T1 vertebral body. So here we can see 1, 2, 3, 4, 5, 6, 7, and you can see the top of the T1 vertebral body. So this is an adequately exposed, this is an adequate lateral x-ray of the spine. The rotation is also correct. And you can see a couple of lines. So the anterior vertebral line is joining up the anterior vertebral bodies, the posterior vertebral line joining up the posterior vertebral bodies, and the spinal lamina line. You can see that between the spinous process and the lamina, there's a sort of there's another slight difference in shading on the X-ray, and that forms a line which you can also trace down, and that gives you an idea whether there's any problems with alignment or anything like that. As you could see on the AP, you can't see the top of the spine because the mandible and the maxilla are in the way. And so we do an open mouth view, also called an odontoid view, and there you can see through the mouth the top of the spine. So what you're looking at there, the two triangles on the sides, they are either side of the C1 vertebral body, and then the odontoid process is in between them, going down to the body of C2. So there you see C1 and C2, and you see it's quite symmetrical, and the gap between each side of C1 and the odontoid peg is the same. You can also get oblique views if you want to look at the neuroforamini, but these are uncommonly obtained, and generally speaking we would tend to go for a CT scan if you're looking for that. To me this looks like a normal lateral really. So what pathologies can we see? Well, if we start with trauma, a Jefferson fracture is basically a burst fracture of C1. So compared to the image you just saw, you can see that this is an odontoid peg view or a through open mouth view, and you can see that the two halves of the C1 body are splayed apart and a little bit of an angle, and there's some subluxation between their articulation with C2 there in the middle. So this because there's been an axial load onto the head, and the atlas C1 has essentially burst apart, separated, and this gives you this appearance. Obviously this patient needs a CT scan and an MRI scan in order to look at this better. A hangman's fracture, named for obvious reasons, is a pars fracture of C2 bilaterally, and what happens is that because if you fracture the pars on both sides, and this will happen in hyperextension or any sudden hyperextension to the neck, then you create discontinuity between the body and the neural arch at the back, and this allows forward displacement called an anterolisthesis of the C2 body, and therefore that can cause a spinal cord injury. An odontoid process fracture, these are quite common, especially in the elderly, and there's a few different types. So type 1 is just the tip of the odontoid process, usually stable. Type 2 is at the base of the odontoid process, usually unstable. And type 3 is through the body of the C2, usually stable. A teardrop fracture is a fracture which essentially demonstrates separation through the middle of the body of a part of the body of the subaxial spine. So it's a coronal split in the body, which usually happens under quite significant energy, and you'll often see some malalignment of the spine with this. But if you see a teardrop fracture but no malalignment, you should still be suspicious that this has been a major injury, and that patient requires more than just plain radiographs, ideally CT scan or MRI scan. You quite rarely will see an X-ray like the one on the left these days, because the patient with a serious injury to the neck like this would probably end up coming in and having a CT of the neck primarily. But if you did see that kind of X-ray, then you would want to lie the patient down, make sure that they had a collar on, probably put them between blocks, get them in the CT scanner as soon as possible. They're at risk of spinal cord injury. The other thing that you can obviously see in the spine is degenerative change, and that you will often see with sclerosis around the end plates, loss of disc height. Sometimes you can see some increased size of the facet joints, and it's often associated with deformity as well, because the arthritis does typically change, can typically change the shape of the spine. So many of those patients will have a scoliosis or some kind of loss of sagittal alignment when you look at the spine from the side on the lateral X-ray. So this is a plain radiograph of a neck, and you can see some sclerosis, some loss of joint space. And we should remember that, often arthritis in the neck, degenerative change in the neck, or spondylosis, all those are synonymous, can cause myelopathy, which is a dysfunction of the spinal cord, in this case due to compression, or radiculopathy, which is typically understood as pain due to one of the nerve roots being compressed. So thoracic spine X-rays. Now, typically in the spine, you find you'll see more problems in the cervical spine or the lumbar spine. But it's important to also be aware of what happens in the thoracic spine, because sometimes serious pathology can present in the thoracic spine. So, thoracic level pain is to an extent a red flag in itself. Common views, as before, AP, and you can look at alignment. You can look at, in fact, you look at ABCDE, right? So you look at the alignment, you look at the bones. You can and so on. And the other views are lateral, and lateral view, you can get another look at the alignment and check to see if there's any fractures. Typically, if people have an osteoporotic fracture, you'll see it on this view. And sometimes they also get something called swimmer's view, which is not here, but if you're trying to look at T1, 2, or 3, and the shoulders get in the way, so if you really want to get an X-ray of that, then you can try lifting one arm and taking a slightly oblique shot through in order to get an idea, but it's not a very clear shot. If you really want to see set, from let's say T1 to T5, and it's not clear on the plain radiograph, then you may need to get a CT scan if you want bony anatomy, or otherwise an MRI. So common pathologies that we see, wedge fractures. So terminology is always important. A wedge fracture is a sort of commonly used term for sort of osteoporotic fracture that happens in later life. And by classification, it should really only involve the anterior column of the spine. The spine is divided up into three columns, anterior, middle, and posterior. Typically, I mean, people have different classifications these days, but most people will refer to it like that. The other would be anterior and posterior, so you basically got vertebral body and neural arch as two separate columns. But anyway, this is usually the anterior column only, meaning the anterior 2/3. And what you get is a depression, usually of the superior end plate, although it can be a fracture of the inferior end plate. And it's kind of like pushing down on a cardboard box. So you see this kind of wedging of the front of the body. And these can happen sometimes even without trauma. And are very painful. And often... and the main differentiating thing that you need to check is to make sure that it's not pathological. I mean, clearly, if they've got osteoporosis, that's a form of pathology. But what we're thinking of here is basically things like metastasis, which can also weaken the bone. A burst fracture is a different kind of injury because it's a high energy injury, typically involving at least two, but usually all three columns. And you can't. Well, actually, you can. So if you look at the AP of this, so you see each vertebra has two circles on either side, and then a line in the middle. It kind of looks like the face of an owl. If you look at the top one, right, you've got a kind of not circle but oval on either side, and then something in the middle, which is like a beak to the lower part of the vertebral body. So that's the two pedicles and the spinous process on the AP. So if you look from top to bottom, the top one is sort of partially seen, so we'll ignore that. The next one down is normal. The next one down is normal. But when you look at the next one down from that on the AP, the two pedicles look wider compared to the one above, and in fact also wider than the one below. So there's some kind of sagittal split in this vertebral body, which is allowing the pedicles to move sidewards away from each other. And then on the lateral, you can also see that there's loss of height in the anterior column, and there's also subluxation. So the vertebra above looks like it's slightly anterior to where it should be, or the fractured one looks slightly posterior. So there's something that's happened there, which is at least in two and probably three columns. And in addition to that, you can see that the pedicles have moved apart. So it looks like a more serious injury than the one we saw on the previous page, which is just of the anterior column and a little bit of loss of height. So this is a high energy injury. You would not expect this to happen without significant trauma, such as a car accident or a fall from a height. Schumann's kyphosis. Now, this is a completely different diagnosis. It's not traumatic, but and it's basically thought to be a kind of osteochondritis, essentially inflammation of the junction between the cartilage and the bone at the disc spaces in the thoracic spine and in development. And what effectively happens is you get this wedging of the vertebrae over multiple levels. By definition, on a plain radiograph, it should be three contiguous levels of 5 degrees or more, and as in wedging of 5 degrees or more, and that's basically the diagnostic criteria. And because of that wedging and the maldevelopment of those vertebral bodies, then you get this kyphosis, so sometimes it's mild. It's actually very common. And so it'll make people a bit round-shouldered, but and normally not cause any major trouble, but it can be severe and cause trouble, and sometimes we do operations for this. It's to be distinguished from a postural kyphosis. So if you see somebody who's a bit round-shouldered and they're worried that they've got a deformity in their spine, because all these teenagers are sort of hunching over these days, and in the past, to be honest, then you do if you do this, the lateral X-ray, If they have wedging, then it's a Scheuermann's kyphosis most likely. If they do not, then it may simply be a postural kyphosis, more easy to deal with physiotherapy. And now we're down to the lumbar spine. So the lower back has 5 vertebrae and then forms a junction with the sacrum, which is part of the pelvis. It's part of the spine, so it's also part of the pelvis. And that's the sort of connection. If you think about it from the lumbar spine, above it you've got the thoracic spine with the ribs, and the sternum and the shoulders are sort of hanging off via the clavicles and the scapulae from the spine, up in the proximal thoracic spine. And then you have an area where it's just spine from L1 down to L5, and then you have the pelvis, so it connects you together in the middle. Common views, as before, you get your AP view. Look for alignment, fractures. You can also check the soft tissues, any extra implants or anything like that. Quite common that people these days have kind of surgery on their lumbar spine. And then we can also get a lateral, which shows the vertebrae from the side. You can see the disc spaces quite easily. You can see if there's any malalignment. And finally, you can get a Scotty dog lateral or oblique view. So the Scotty dog is, as shown in this picture, essentially you see a kind of ear, which is the superior articular facet. The eye, which is the sort of laminar end on, and then you see the inferior facet as well, the pars going down to the inferior facet. So this is a good view for seeing if there's any fracture in the pars. Although, to be honest, this is not done anymore. It's kind of the vogue is now that if you suspect a pars defect, then you should do an MRI scan, and if it's not clear from the MRI, you should do a CT. So Scotty dog views are very rarely done, but if you don't have access to cross-sectional imaging, I guess it could help. So what do we see on lumbar spine x-rays? Okay, so chance fracture. So a chance fracture is a shear injury where you have essentially a force which has passed all the way through the spine from front to back and injured structures from front to back, right, from the anterior vertebral body all the way to the back of the neural arch. And typically it could be a seatbelt injury, or some other kind of flexion distraction type injury can also cause what we would call a chance fracture. But this should be noted, that could be through the vertebral body, so you can have a bony chance fracture, so going through the body and the pedicle and neural arch all the way through to the back, or it can be a soft tissue chance, so you may have some element of bony involvement, but it then also passes through the disc and ligaments. So you can, and it really sort of depends on where the force is and the integrity of the structures that you're dealing with, because at different times in life, sometimes the bone can actually be stronger than the ligaments, but normally the ligaments will hold on better, but you can have a combination of both. So it's different. I mean, you may pick that up. You can see an injury that's of that vertebral body in the middle of the picture on the lateral, and with the eye of faith, you can also say that's probably the case on the AP as well. It looks like it's a thoracic level rather than the lumbar, but I think you need cross-sectional imaging really to be sure that that's a chance fracture. Burst fracture we've already talked about. This is, I think, exactly the same image. So as before, you can get in the lumbar spine. And wedge compression fractures similar to the thoracic spine, where you've just got that depression of the superior end plate there. The posterior column is intact. The middle column looks intact. So if you look at the back of the vertebral bodies, height has not really been lost. It's just an anterior column injury, really. And so these are kind of low energy injuries, different from the other two that we just saw. And the next diagnosis is spondylolisthesis. So spondylolisthesis is where one vertebra slips forward compared to the other, and that can be in different stages. So what you can see on the image is that the anterior vertebral body line, the posterior vertebral body line, they don't line up, although the spinal laminar line probably still does line up. So this suggests to me that there's pars defects. There's no significant dysplasia, so this suggests to me that it's possibly due to a stress fracture or some kind of traumatic injury, actually. But there is some disc abnormality there, so difficult to say for sure, and you'd need more imaging in order to be able to clarify exactly the cause of this. But essentially, in terms of classification, if the slip is up to 25% of the front to back distance or back to front distance of the end plate, then that's stage 1. 25 to 50% is stage 2. 50 to 75% is stage 3, and 75 to 100 is stage 4, and stage 5 is spondyloptosis, is where the vertebra is entirely in front of the other vertebra. You can see degenerative disc disease and sometimes and osteoarthritis. As we said in the previous imaging, you can see subchondral sclerosis, facet arthrosis, loss of disc height. These would be the most common findings, and then sometimes malalignment, spondylolisthesis, degenerative scoliosis, lateral listhesis. All these things are common, and you can see them on plain radiographs. And actually, plain radiographs are the best way to get an idea of the overall alignment. You should do whole spine, AP and lateral x-rays to look at that. What we have on the right hand side here is actually a myelogram. This is sort of historic, really. Not done very frequently anymore because you would just do an MRI scan. But if you put some dye, some contrast into the epidural space and then which you can pick up on X-ray or you can pick up on CT, in this case on X-ray, then it may give you an idea that there's stenosis. And it looks like there's multi-level stenosis on this myelogram because at the level of each disc, you can see that there's a kind of pinching of the contrast that's in the canal. But you will not see this kind of image very often these days. Spinal infections. So typically you will see loss of disc height and sometimes deformity with the spinal infections. You may see osteolysis on either side, and that is the sort of hallmark, because you can get loss of disc space with degenerative disease, but if you're beginning to see areas of bone resorption on either side on an X-ray, then that would certainly make you suspicious that there was a more aggressive process going on, either tumor or infection. But usually a tumor will be a vertebral body centric process, whereas infections tend to be disc centric processes. So that leads to the the sort of radiological adage in spine, which is bad disc, good news because it's probably infection, which isn't a great thing, but you can treat with antibiotics. Good disc, bad news, right? Because if you've got a destructive lesion that's in the bone, it's more likely to be tumor if the disc looks good. So anyway, spinal infections you may be able to pick up, again, need an MRI scan, and then malignancy. So with malignancy, the most common thing, which is, I can't see that it's really shown on these plain radiographs, but going back to what we were talking about before, you can see the pedicles on either side and you can see the spinous process in the middle. And the most common thing you will see in terms of malignancy in the spine, if on an X-ray, that you may pick up is loss of one of the pedicles. So if you imagine that to be an owl's face, the two pedicles and the spinous process in the middle, is sort of called the winking owl. So you can see one eye very clearly, but the other eye seems to have disappeared, and that's because the metastasis often will kind of obscure one pedicle, and then you don't see that pedicle properly on the X-ray. You can obviously get fractures and things like that, and if you see, and that's what we talked about before, that if you see a new fracture, then you should be suspicious that that could represent, is that pathological? Is it because of a tumor? And then the sacrum, the lowest part of the spine, also really part of the pelvis. You can obviously see an AP, which will show you the sacroiliac joints, the L5S1 disc, and the overall shape of the sacrum, which you can see here. And then we've got the lateral view of the sacrum, and there you can look at the overall curvature. You can see if there's any fractures, and you can also look at the soft tissue around it. Typical, or not typical, but rare tumors that form in the sacrum can then cause a big soft tissue density, particularly anteriorly, sometimes posteriorly. Chordoma is one of the ones, which is a notochordal malignant tumor. Pretty rare, 1 in a million, but could be seen if it was large. Just anterior to the sacrum is the rectum, and then anterior to that is the genitourinary systems. So, if there's abnormalities related to those two things, you may also see them on a lateral of the sacrum if you look at the soft tissues. So the common things that we'll see: a fracture. So here you can see a fracture through the lower part of the sacrum, and there's some malalignment. So this is obviously a high energy trauma, which causes a fracture S5. Actually, you can see this kind of thing with a heavy fall onto the bottom. So you see this kind of thing sometimes when people have slipped on ice and just sort of fallen on their bottom or something like that. It heals uneventfully. You don't need to do anything about it. Sacroiliitis. This is a lumbar spine X-ray, but you can see bilaterally that there's where those sacroiliac joints, so you can see the sacrum at the bottom, you see the ilium, which is the big pelvic bone there on either side, and then the sacroiliac joints should be in between that, but they look a bit white on these images. So sacroiliitis is probably easiest to pick up again on an MRI scan because you can see edema, but you can pick it up on an X-ray as well if it's florid like this. Sacroiliitis is something that can cause pain, but is often associated with spondyloarthropathy, things like ankylosing spondylitis. So it's quite important to pick it up because that would require rheumatological input, and they may need a different form of treatment. This is not muscular back pain or degenerative change. So let's go through some cases. Case 1. Here we've got a 35-year-old. He's presenting after diving into the pool and hitting his head on the floor of the pool. He's got neck pain, but examination is fine. He does not have any neurological deficit. And there's a bit of tenderness over the upper cervical spine. And he has obviously AP lateral and odontoid peg view. So what does the X-ray show? What is the diagnosis? And what is the management? So it's you can see that the lateral masses are spread apart on the odontoid peg view. So this is a Jefferson's fracture, a burst fracture of C1. And this patient, there's a few different options, but depending on the cross-sectional imaging, CT and MRI, you might be able to manage him in a collar. If not, a halo vest is used in this kind of scenario, actually, where you just essentially, it's like an external fixator. You put some pins in the head and attach it to a vest that you wear. It's all connected by metal bars, so it holds your head still as the fracture is healing. Surgery for Jefferson fracture would have to be a fusion of C1 and C2, or maybe occiput to C2 or even C3, so it would cause significant stiffness. So you'd have a reduction range of movement of the neck. But obviously, if it's an unstable injury and there's risk of spinal cord deterioration at C1, 2, that could be a life-saving operation. Case 2. Here we go. A 72-year-old woman with amazingly postmenopausal, with a history of osteoporosis, and she has slipped on a wet floor and landed on her bottom, and she's got pain in the middle of her back at rest, and it gets worse when she moves around. She's neurologically fine. You do a thoracic spine x-ray, and what do you see? So obviously you always say this is a plain radiographs, AP and lateral, of the thoracic spine. It is adequately exposed on the AP, but on the lateral I cannot see the proximal thoracic spine clearly. So if I was suspicious of an injury there, I might have to get further imaging. Looking at the alignment, it's satisfactory, although there's some slightly increased kyphosis, but I can see wedging of the anterior part of one of the vertebral bodies, which I can't count on this x-ray because it doesn't give me any landmark in order to count the vertebra, but it's in the proximal thoracic spine. So it's an anterior vertebral body compression fracture, and the management is initially pain relief, possibly bracing, possibly physiotherapy, possibly vertebroplasty or kyphoplasty. Okay, and then we have a 50-year-old, and he's come in with low back pain, leg pain intermittently, a bit of tingling from time to time. Otherwise, neurologically he's fine. Now, this is a lateral x-ray. The abnormality is actually just here. So you can see the vertebral body just there and there. Okay, so that's the bit that you're looking at. So what have we got here? Diagnosis. What's the management? Okay, so you can see that there's a spondylolisthesis and antrolisthesis of L4 over L5. The diagnosis spondylolisthesis, based on the history, looks like it may well be degenerative, although it does look like there's probably a pre-existing pars fracture or pars defect here. And the treatment is initially analgesia, physiotherapy, so a conservative approach. If it's not working, then surgery in the form of a fusion is usually quite helpful. Okay, and now we have another scenario. 45-year-old from South Asia, 3-month history of worsening back pain, night sweats, weight loss, no trauma. He doesn't have any neurological deficit. He has a bit of tenderness, and he has an obvious gibbous. He has which is an acute kyphosis in the spine. You've got these x-rays. What do you see? So they're not hugely clear, but what you can see is that there's 2 vertebral bodies, probably 1 and 12, which are collapsed due to some kind of destructive process that's happening between them, and I believe, and it's causing this kyphosis. And on the AP, you can just see this increased density in that area. It's because you're sort of got superimposed vertebrae on top of each other when you do the AP. So I will say, although, with TB, it's the one which could be bad vertebral body, not bad disc, but nevertheless, let's say this one is a bad disc scenario, i.e. it is an infection, and well, let's go to the next slide and see what you get. Right, you got it. So it's vertebral height destruction, loss of disc height. Uh, there is a paraspinal abscess. I mean, you can't see that on an X-ray really, but if you did an MRI scan, you should certainly pick it up. And that is tuberculosis. And when you've got this kind of collapse, we also call it Pott's disease. It has an eponymous name. And the first thing you want to do is get a biopsy because you want to confirm that the infection is in fact tuberculosis. You can't just assume that based on his ethnicity or where. And then once you've got the diagnosis, you can also get sensitivities. And once you've got the sensitivities, you can give the appropriate tuberculous treatment. I do know that empirical treatment is often offered in some parts of the world, but I think that the standard of care here would be to get a sample, and usually if there's a paraspinal abscess, then you can often drain that prior to treating with antibiotics. In terms of the treatment, obviously if there's instability or severe, if there's instability, then surgery may be indicated. Neurologically, they often decompress well on anti-TB medications. That you often don't need to do surgery for that. In fact, the primary indication for surgery in these kinds of situations would be progressive deformity. So, have a systematic approach to assessing your X-rays. Go A, B, C, D, E. You can mention them. So start off. What are you looking at? Plain radiographs of the spine, cervical spine, AP, lateral, whatever it may be. Secondly, is it adequately exposed? And then go on to, you can talk about the most obvious abnormality if you wish, if there's something obvious, but don't forget to then go through A, B, C, D, E. Make sure that you have an idea of the difference between fractures, degenerative change, infection, and tumour. Those are the main things that you might be able to see on X-rays. And always be aware that cross-sectional imaging, such as MRI scan in particular, are really the gold standard and a mainstay of investigation of problems in the spine. So if there's a suspicion that there's something more going on, you can't see much on the X-ray, an MRI may be required. There is NICE guidance and NHS guidance on management of back pain or spinal conditions, in particular NICE guidance. That's really the main thing to take into consideration when you're managing these patients. Thank you very much. Join our WhatsApp.